I now request Dr. Suchet to felicitate Dr. Rajiv and Dr. Mridu as a token of appreciation. I now invite Dr. Ruby Sharma, Associate Professor, Ames Mohali, to kindly come on stage and deliver the vote of thanks.
Good morning, one and all. It is with great pleasure that I stand here before you to deliver the vote of thanks for this esteemed medical CME and workshop on electroneuromyography. On the behalf of the Department of Physiology, Ames Mohali, I would like to extend our deepest appreciation and heartfelt gratitude to all those who have contributed to the success of this event. First and foremost, I would like to thank our chief guest, Dr. Avnish Kumar Sir, DRME Punjab, who, despite his busy schedule, has managed to come and grace the occasion. Thank you, sir. I would like to thank our worthy Director Principal, Ma'am Dr. Bhavneet Bharti, who has always been supportive to our initiatives and always encourages us to strive for the excellence. Thank you, ma'am. I also express my thanks to our dynamic medical superintendent, Dr. Navdeep Singh Saini, who could not join. He's busy in the hospital side, for his constant support and motivation. We also want to extend our sincere thanks to the Punjab Medical Council for accepting our proposal for the CME and granting us 4 credit hours. Further, I would like to express our gratitude to our esteemed speakers for all the sessions. Their expertise and knowledge in the field of this neurodiagnostic tests will truly enrich our understanding and open new horizons in the realm of healthcare. We also want to extend our sincere thanks to our organizing team under the able guidance of our HOD ma'am, Dr. Suchet, whose tireless efforts and meticulous planning has made this conference a reality. Our heartfelt gratitude also goes out to the sponsors and the exhibitors who have supported this event. We value their contributions and recognize the significance of their partnership. We extend our gratitude to the support staff, to the technical support team, and all those who have been working behind the scenes, who have worked diligently to ensure the smooth running of this CME. Last but not the least, we would like to express our sincere thanks to all the delegates who have managed to come and attend this CME. Your presence and active participation mean a lot to us, and we are grateful for your presence in making this event a vibrant one. We hope that you all have a great learning experience today and take back the valuable knowledge that you can apply in the field of electroneuromyography. Thank you.
Thank you, ma'am. Now let us welcome our second speaker, Dr. Sonia Kocher, additional professor, Ames Bathinda, a dedicated academician with 18 years of teaching experience, specializing in medical education, sleep medicine, neurophysiology, and autonomic function tests, a certified BLS and ACLS instructor. She has established AFT, neurophysiology, and EEG labs at Ames Bathinda, certified in autonomic clinical skills and advanced polysomnography and lifestyle medicine. I will take us. She will take us through the sessions on late responses on challenges in NCS. She will educate us on the physiological basis, clinical significance, methodology, and interpretations. I invite you, our esteemed speaker, Dr. Sonia Ma'am, to kindly grace the stage.
Welcome, madam. Please start. Thank you. So, at the offset, I would like to extend my warm greetings to all, and special thanks to Director Professor Ma'am and Dr. Suchet for organizing such a CME and giving us a platform to share the knowledge. And my gratitude to their teachers and mentors and colleagues and friends. So, I'll be talking about late responses and the challenges in nerve conduction studies. So, the previous speaker has done some justification initially of the plexus and the okay. That is the plexus and the roots. So whenever a nerve is stimulus is applied, it travels in two directions. So we have the stimulus here. The stimulus will either the information passes along the normal physiological path, that is the orthodromic peripheral stimulation, which results in what we call as the CMAP or the M response. While when it goes towards the anterior horn cell stimulation, that is antidromic against the normal physiological pathway, we say it ends up in a late response. And today we'll be talking about two important late responses which we generally do as a protocol for the nerve conduction studies, that is the F wave or the F response and the H reflex. Mind it, we say it as F wave or F response and not a reflex, and I'll be coming to that. Why do we say it as a response or a wave and not a reflex? So most of the time we are dealing with the F responses in routine practice, and H reflex is something which is a bit difficult to elicit also. So F response, it is a late motor response. Why I call it as late? Because first we have the M response, and after some duration of time, maybe a few milliseconds, we get the late motor response, which is because of the antidromic conduction, and that is why we call it as a late motor response. So it was first described by Megaladry and McDougall in 1950. The F wave derives its name from foot because it was first recorded from the intrinsic muscles of the foot. And as I said, it is not a true reflex, but it is a pure motor. And sorry, just to show here the difference between the H reflex and the F wave, this is not following the reflex arc, whereas H reflex shows a reflex arc. That is why we call this as an H reflex, and this is purely motor because the impulses are traveling to and fro from the anterior horn cells in the spinal cord itself. It is not a reflex. So the mechanism, so F wave is generally generated as a result from antidromic stimulation of the motor neurons involving conduction to and from the spinal cord and occurs at the interface of the peripheral and the central nervous system. So here is the stimulus which is given. So orthodromically, it is responsible for causing the M wave, and antidromic impulses, when they pass to the spinal cord, they are going to activate the anterior horn cells, and this activation, this antidromic stimulation of the anterior horn cells is the one which is going to bring the late response, which we say as the F wave or the F response. So how do we elicit F responses? The settings on the console consist of electrode placement, and this electrode placement is same as for motor nerve conduction study. How do we place it in motor nerve conduction study? That is the muscle and the tendon montage electrode placement which we are using. Say if we are talking about the median nerve, we have the active electrode. The recording electrode consists of the active and the reference electrode. Active electrode is placed over the center of the belly. Center of the belly is important because in EMG probably it is slightly off the center, whereas here we are keeping it directly on the center of the muscle belly, and we have the reference which is towards the tendon. And then we have the ground electrode, which is generally between the recording and the stimulating electrodes, and the stimulation is provided at the wrist for the distal and the elbow joint at the proximal levels. So electrode placement is going to be the same for the motor nerve conduction studies. Since the F wave or the responses are pretty low in their amplitude, so we are going to increase the gain to up to 200 microvolts with a sweep speed of about 5 to 10 milliseconds per division. And very important is the stimulation for F wave. It always has to be supramaximally stimulated. And another important thing which we need to note for eliciting the F response is the cathode. We have the stimulator, which is again having a cathode and an anode. So generally the cathode is on the side of the active electrode. How we generally memorize is black towards the black. Active electrode is black and the cathode is black. But here, for F response to be elicited, we generally place the cathode, we reverse the polarity of the simulator, and we are going to place the cathode proximally to avoid the anodal block, which generally occurs because of the hyperpolarization which occurs at the anode, and it will hamper the antidromic stimulation which is required for eliciting the F response. Now, F waves we generally do not see when the person is sleeping or sedated, but this should not be taken as some pathology. So this is something which is quite normal, and if you're not getting a persistent F wave or an absent F wave when the person is sleeping or sedated, we should not come out to conclude on some pathologies. And again, if you're not getting the F wave or the response being recorded properly, we should ensure first that the stimulation is supramaximal. And second, if we are still not getting it, we have to go for the Gendressix maneuver. So Gendressix maneuver is the one which is where we are going to tell the subject to make a fist of the contralateral hand or to clench his teeth before we give the stimulation. So this is how we can cause an F wave response to be there if we are not getting it, but only to be tried if we are not having the F wave response initially, then we should go for the Gendressix maneuver. So this is showing you the placement of the electrode. So we have the ground electrode. This is for the median nerve, and F responses are generally elicited in almost all the motor nerves. Maybe a notable exception for this is the peroneal nerve, and rest all the distal nerves. Distally we are recording and we are getting the F responses. Again, distal nerve stimulation is the one which is giving off the responses, and I'll come to the significance of that, because distally in the upper limbs we generally have the median and the ulnar nerve for which we are eliciting the F responses. So they correspond to C8 and T1 nerve root. So if we are going to go for the radiculopathies, maybe C5, 6, C6, that is again going to be a limitation for this. We won't be able to do it because we are distally stimulating these nerves. So here we see the median nerve stimulation where we have the active electrode, that is the black one, placed over the center of the belly of the muscle, and we have the reference electrode about 3 to 4 centimeters away on the tendon, probably the ground, which can either be placed on the dorsum or in between the recording and the stimulating electrode, and we have the stimulator here. Now this again has to be noted again. The stimulator is having cathode and anode, and here the polarity is reversed. Normally in motor nerve conduction studies, we have black cathode along with the black to the black. But here the polarity is reversed to get a proper F wave or the F response to be elicited. And this is how we are going to get the motor response first, followed by the F wave responses, because these are late motor responses. And if you note here, what we see is the difference in the appearance of the F wave. We generally have a train of 10 or 20 stimuli being given to elicit the F wave responses and to come out with its attributes, which will be going further. So what we see here is all these F waves which appear with subsequent stimulation, they all vary in their latency. They are going to vary in their latency, they are going to vary in their duration, as well as in the configuration. You're not going to get the same type of F wave with every stimulation. Why? Because we are going to activate another different set of interior horn cells with each stimulation. So that is why we are going to get different F waves which vary in their latencies, their configurations, as well as their durations. So these are the attributes of the F response. We need to know the latencies. Most important and most routinely done is the minimum F wave latency. We can also go for the maximum latency and the F mean latencies. The amplitude, the FM ratio, the persistence, chronodispersion, and F estimates. So this I've already told you that F waves are going to vary with each stimulation because of the anterior horn cells that are activated, different ones which are activated at each time. So latencies, the F minimum, the minimum F wave latency is the latency of the fastest conducting fibers. And for the upper limb, generally when stimulated at the wrist, the distal nerve, we are going to get it in a range of 25 to 32. Whereas for the lower extremities, it is in the range of 45 to 56 milliseconds. So this is the most important parameter which we routinely do. And then we have the F maximum latency, that is the latency of the slowest conducting fibers. The amplitude, now F waves, they are actually small CMAPs and they are going to represent only 1 to 5% of the CMAPs. The persistence is the number of F waves obtained divided by the number of stimulations. And normally we are going to see 80 to 100%, 100% of the persistence of F waves. And for the routine, we generally say it should always be more than 50%. The persistence should be more than 50%. Chronodispersion is described as the difference between the maximum latency of F wave and the minimum latency of F wave. And for upper limb, it is generally up to 4 milliseconds, and for lower extremities, it is up to 6 milliseconds. Now, F estimate is something which is of importance to us because generally what is seen is we are having an unusually tall patient and they may have a prolonged F wave latency because it depends on the length also. So considering those criteria, like the distal motor latency, the conduction velocity, and the patient's limb length, they all are going to affect the F wave latency, and therefore we determine the F estimate. What is this F estimate? This is basically from the stimulation, the whole pathway is tracked by this. We are going to take this segment here when the information passes antidromically to the anterior horn cells. Then we are going to see at the level of synapse, there is a delay of about 1 milliseconds, and then the signal comes back to the point of stimulation. So this time is basically distance divided by the conduction velocity. And therefore, we are going to double this because twice we are traversing this distance. And then we are going to add 1 milliseconds at the synapse plus the distal latency, which is this Z area here, from the stimulation to the muscle response. So taking account of these, the distance, how do we measure this distance D? This is from the stimulation of the nerve to a mark. Like, for example, in lower extremities, we generally take xiphoid process to the point of stimulation, and for the upper limb, we take C7 spinous process to the point of stimulation for the upper limbs. So this is how we are going to determine the F estimate. And what do we consider here? We have to compare the F minimum with the F estimate, and generally, the minimum F wave latency is always less than the F estimate. And if it is more than the F estimate, it indicates an actual prolonged F wave response. So then abnormalities in the F wave, as I said, it is more precisely going to tell us more about the plexus and the radiculopathies. So polyneuropathies is the one where conditions where we get prolonged F wave responses. Distal entrapment neuropathies, the carpal tunnel syndrome, it is prolonged. Early polyradiculopathies, prolonged absent F wave with normal CMAP. And in case of severe axonal loss, we may have a prolonged F wave, and there can also be an absent F wave response. Because if we are not getting the CMAP, if CMAP is itself very low, we are not going to get the F response. So that is perfectly fine. In case of severe axonal loss, we may not get an F wave or a F response. The limitations of the F response. It is difficult to elicit the F response in radiculopathies involving C5 and C7, and I think I've made it clear earlier because it is the distal nerves for which we are seeing the F latencies, and they generally correspond to C8 and T1 levels. If there are predominantly sensory symptoms, because it is not going to the sensory part of the spinal cord, in radiculopathy, F responses are going to be normal. F response will be normal in a minimum demyelination, and for F minimum to be delayed, most axons need to be involved. Hence, disease has to be severe enough to give us a prolonged F wave latency. And very important, whenever we are dealing with unilateral symptoms, we also always have to compare both the sides and then make the report out of it. Now I come to the H reflex. Now H reflex we generally say is the electrical counterpart of your ankle jerk, where we are not stimulating directly the muscle spindles but the 1A fibers. So this was first elicited by Hoffman in 1918. And this is what we call as a true reflex, because we have the pathway which is similar to the stretch reflex. The only difference being we are not stimulating the muscle spindles here. The pathway is going to be the same. So what we are doing is we are eliciting it from the tibial nerve in the popliteal fossa by stimulating the gastrocnemius or the soleus muscles. So the limitations, one of the important limitations is the site. As for the F wave, we generally say all the nerves, we can have the F responses except for the peroneal nerve. But in case of H reflex, we generally restrict ourselves only to the tibial nerve at the popliteal fossa, where we are recording from the gastrocnemius or the soleus, though we have other sites also to be mentioned here. So the H wave is the expression of monosynaptic reflex which runs in afferents from the muscles and back again through the efferents of the same muscles. So what we see here is we have this electrical stimulus being given here, and this is going to go through the 1A fibers to the dorsal column of the spinal cord, and then it is going to activate the motor neurons, the motor horn cells, and cause the response. So this is an actual reflex arc, and therefore we call this as a H reflex and not a wave. So location and stimulation for the H reflex. The H reflex is a monosynaptic reflex consistently obtained in normal individuals only by stimulating the tibial nerve submaximally. Now this word again is important. For F wave it is supramaximal stimulation, but for H reflex we go for the submaximal stimulation, generally in the popliteal fossa, while recording from either the gastrocnemius or the soleus muscle, and it is similar to clinically elicited Achilles reflex. And Achilles reflex, we all know, corresponds to the root value of S1. So it is going to help us differentiate between S1 radiculopathies from others. So the H reflex can also be recorded from the median nerve, recording from the flexor carpi radialis muscle and stimulating in the elbow, and also from the femoral nerve recording from quadriceps muscles. So we can either do it for the gastrocnemius or the soleus, or we can do it from the flexor carpi radialis, where we are going to make a line drawn from the medial epicondyle and the styloid process here, and we divide this line into proximal 1/3 and distal 2/3. At that point, we are going to do the recording for the flexor carpi radialis muscle. But again, when we do it actually in the lab, it is generally very difficult to get the H reflex. So there has to be an optimum location for this. And how do we decide this optimal location? We generally draw a line from the popliteal fossa posteriorly to the Achilles tendon up to the mark where the medial malleolus flares out. And we divide this line into 8 equal segments, and it is the 5th and the 6th segment which we consider as the optimum location for eliciting a greater amplitude of the H reflex or a proper amplitude of H reflex. So this again has to be kept in mind, because when most of the technicians do, they generally don't see the anatomical, optimum location for this. So this is how we apply the electrodes. We make the person lie prone, and we are going to put the active electrode, that is G1, on the soleus or the gastrocnemius muscle. For the optimum location, I said we are going to draw the line, divide it into 8 equal parts, and 5th and 6th segment is the exact point over the gastrocnemius or the soleus muscle where we are going to elicit the H reflex. The G2 reference is placed over the Achilles tendon. Usually it is 14 centimeters away from G1. So this is G1 and this is G2 here. This is the ground electrode and this is the stimulator. And where do we place the stimulator? We are going to put it over the back of the over the popliteal fossa, over the middle of the popliteal fossa to activate the tibial nerve. So this is the most common thing which we are doing. And the settings on the consoles, the electrode placement, I've already told you, the gain is 200 to 500 microvolts. Sweep 10 milliseconds per division, and stimulation here is not supra but it is submaximal, because we are going to elicit the response by 1A fibers. which will be earlier. As it is overtaken by the motor response, this H reflex is going to decrease in the amplitude and finally disappear. And again, important, the cathode, the polarity of the simulator again has to be reversed for this case. So here again, the cathode is proximal to avoid the anodal block. So for both F response and H reflex, the cathode polarity has to be reversed, and for F reflex, we have to give a supramaximal stimulation, and submaximal stimulation is the one where we are going to start getting the response for the H reflex. So this is how we do it in our lab, where we are going to place the patient or the subject in a prone position. We are going to draw a line from here to here, fifth and sixth segment, equal divisions which we made. Fifth and sixth is place where we are going to place the active electrode over the soleus and the gastrocnemius muscle, and we are going to place at about 14 centimeters away on the Achilles tendon, the reference. This is the ground, and this is the point at the popliteal fossa where we are going to stimulate it. Now, as you see here, as we increase the current from lower to higher, generally we get 20 or maybe 30 recordings by different stimulations, by increasing the stimulation strength of current. So what we see here is that we are going to get the H reflexes first, and as we increase further, we get the M response, and as soon as we get the M response, the H reflex amplitude is going on decreasing. Ultimately, it is going to disappear. So submaximal stimulation for sufficient time, if given, H reflex is seen with no M response. With maximum stimulation, the amplitude of H reflex is going to decrease, and we are going to see the M responses start appearing. And with supramaximal, the H reflex may vanish and M response appears. So this is how we are going to elicit the H reflex. But again, important is the placement or the optimum location where we need to put our active electrodes. And obviously, the submaximal stimulation, the reversal of the polarity at the cathode has to be taken into account. So affected versus the normal limb. The normal subjects, the latency of H wave should be less than 34 milliseconds while recording from tibial nerve, depending on the length of the leg. H reflex varies with the limb length, and typically the H reflex with the shortest latency is measured, and it is compared with a set of normal controls for the height. And if we have unilateral symptoms, then we need to check for the side-to-side onset latency difference, which should be less than or equal to 1.5 milliseconds. If it is more than this, it has to be considered as significant. The HM ratio is again the crude assessment of the excitability of the anterior horn cells. The HM ratio should be less than or equal to 50%. An increased ratio may indicate upper motor neuron lesions. The prolonged H reflex is a significant finding in polyneuropathies, proximal sciatic and tibial neuropathies, lumbosacral plexopathies, and the lesions of S1 nerve root, because this is the nerve root which is responsible for an ankle jerk. So just to show you how important this can be in different case scenarios, I've put up a few case scenarios here. The first one is a patient, 58-year-old male with a complaint of gradual onset of numbness and tingling in both feet ascending to the lower legs over the past 6 months, with a history of diabetes, type 2 and hypertension. The neurological examination shows bilateral reduction in pinprick and vibration sensations up to the mid-shin, and mild weakness in toe extension and flexion, normal upper limb strength and sensations, deep tendon reflexes are showing the reduced ankle jerks bilaterally. So the NCS and the EMG studies were done on the subject, and it showed a prolonged latency in the lower limb nerves with reduced persistence, especially in the tibial nerve, along with the findings in the conduction nerves also. So this prolonged F wave latency and reduced persistent, slowed conduction velocity and reduced amplitude, they all suggest generalized neuropathic process. And so in the light of the history and the clinical findings, it can be considered as a polyneuropathy, which probably is due to the diabetes. So this is how the F wave abnormality or the prolongation of the F wave latency or the persistence and other attributes can help us come to a precise diagnosis. Another case of suspected radiculopathy, 45-year female, complains persistent right-sided lower back pain radiating to the thigh and leg for 3 months with no significant past medical or surgical history. positive straight leg raise test on the right, which shows signifies involvement of the radiculopathy probably. The reduced sensation to pinprick in the right L5 dermatome, weakness in the right big toe extension, and deep tendon reflexes shows reduced right ankle jerk. So here again, we have the prolonged latency in the right tibial nerve as compared to the left side. So whenever we are having a unilateral symptoms, we need to compare it with the other side with a normal F wave latency persistence in the upper limb nerves. So this clearly points out that there is the radiculopathy might be present, which is going along with the clinical signs and the history also. And then we have the third case here, the H reflex S1 radiculopathy, which again is a 52-year-old male patient with left-sided low back pain with radiation to the left posterior thigh and calf for 4 months, history of lumbar disc herniation, positive straight leg raise test on the left, reduced sensations in the left S1 dermatome, weakness in the left ankle plantar flexion, and absent left ankle jerk. Again, the presence and absence of the H reflex, absent H reflex on the left side, which shows the chief complaints and the examinations also coincides with it, and normal H reflex on the right side, plus the normal NCV and the chronic denervation pattern which is seen in EMG. This probably suggests a left S1 radiculopathy. So this is how with the F wave and the H reflexes, we can come to the precise documentation of the results, whether they are pointing to radiculopathies or not. And in the end, we have the challenges in the nerve conduction studies, where we can have the anatomical variations in the nerve anatomy can affect the nerve conduction studies, resulting in accessory nerves or anomalous nerves. And most frequently encountered is the Martin-Glover syndrome, which is probably present in 20 to 30% of the population. Then we have the technical factors, the electrode placements, the stimulus intensity, and the filter settings. They all can affect the results. The patient factors, age, temperature, medical conditions, they all can affect the results. Interpretation. Correct interpretation of the NCS results require a thorough understanding of the underlying anatomy, physiology, and the technical factors. And very important, the correlation with the clinical findings. The NCS results should be correlated with the clinical findings to ensure accurate diagnosis and treatment. So the take-home message, the F wave and the H reflexes are indispensable tools in the neurophysiological evaluation of peripheral nerve disorders. Their ability to assess the nerve segments distant from the stimulation site offers unique insight into the health of motor neurons and proximal nerve structures. Mastery of the technical nuances and thorough understanding of the underlying neuroanatomy and physiology are crucial for the accurate interpretation of the tests. As a part of comprehensive neurodiagnostic evaluation, they provide a valuable information guiding the diagnosis, management, and prognosis of various neuropathy conditions. I thank you all for patient hearing. Thank you.
Thank you, ma'am, for educating us on late responses and challenges in nerve conduction study. We now invite all delegates to join us for the open house discussion. If you have any queries related to this session, please feel free to raise your hand. I now request Dr. Madhu, HOD, MMU Mulana, to felicitate Dr. Sonia Kochar as a token of appreciation. Our next eminent speaker is Dr. Jayanti Pant, additional professor, AIMS Rishikesh, a passionate researcher in environmental toxicology, high altitude physiology, and electromyography, with 30 publications in peer reviewed national and international journals and one patent granted. Recipient of several prestigious awards, including the Professor R.C. Shukla Oration Award, B.K. Anand Prize, Best Teacher Award, and Best Researcher Award in the year 2023, also recognized with national and international travel grants and honors for outstanding contributions to medical science. She will take us through the session on fundamentals of electromyography. She will make us understand the basic principles, physiological basis, types, techniques, equipment, and clinical applications of the same. I now request our next eminent speaker, Dr. Jayanti, to please join us on stage.
Okay. Good afternoon, everybody. And at the outset, I would like to thank Professor Chet ma'am for inviting me over here in this CME workshop. And I would like to take you today the procedure which we are following while performing the EMG. And hopefully, we are also doing the workshop in the hands-on training. So there, I'll tell us how we are actually doing it. So to begin with, so now this is what is an electromyography. It is the recording of the action potential of the muscle fibers. It's electromyography. Myography means muscles, the study of the muscles. And of course, it is one of the oldest techniques which was started and it's taking place. And of course, it is quite helpful for the diagnosis of the radiculopathies and also for the myopathies. Then coming to the types of the EMG, we have generally two types of EMG. One is the surface EMG and the other one is the needle EMG. So surface EMG is where it's a non-invasive procedure. So you are just placing the electrode over there, as you can see. Uh, sorry, as you can see, and you can take the recordings. However, we are not getting this is just give you about the idea of the MEPs, or the amplitude of the motor unit potential, action potentials, with not much details of the other aspects, which we can definitely get through the other one, that is the needle electromyography. And as you can see, but however, this is a invasive procedure where you have to insert in the needle electrode, and then we do study number of different phases while we do the procedure. So that what I will be taking you through. So now, what are the different types of needle EMG which is available? We have broadly four types. That is the concentric needle electrode, the monopolar needle electrode, single fiber, and the macro electrode. So if you see one of the photographs I've kept over here, so this is a concentric needle electrode, you can see, and you can see there is a concentric. If you can see, this is just going round like a concentric configuration. And interestingly, this both the electrodes and both the nodes are there within this concentric, with the active one at the center and the shaft as the reference one. So that is why you do not need any special reference electrode to be attached in this case, and therefore it has got an upper hand in relation with the monopolar, where there is the shaft is Teflon coated, and then you have to place a reference electrode also along with it. So so everywhere now, suppose if you have to do the EMG of different muscles, so everywhere you have to keep changing the reference electrodes as well. So this problem is being sought out when we are using the concentric needle electrode. You only have to insert the needle. You have ground electrode at one place, and then you keep on inserting in different muscles, and can get rid of with this special placement of the reference electrode. So that's why we prefer the this concentric one instead of the monopolar. So if you see the detection area again, so detection area is of course not this for concentric and the monopolar, and you can see this is quite a beveled kind of appearance over here. And importantly, so this gives a kind of a teardrop configuration as compared to monopolar. Otherwise, The not much difference is there, but the amplitude, of course, is higher achieved in monopolar, but still we are getting good results with the concentric, and we don't need that reference electrode every time being removed. And then we have, sorry, we have the single fiber, which is required where the area is very small, and this is specially required to when we want to understand any neuromuscular problems, and only the definitive area or very single small area has to be taken care of, so that then we are using it. And finally the macro electrode, where the area is broad, but preferably everywhere, most of the places, we are using the concentric needle EMG. Now, how do we do? Go ahead. First and foremost, because this is an invasive procedure and requires lots of patient cooperation. So we have to explain the patient that this is going to be painful for you. We are not using any anesthesia as such during the procedure. So, well, you have to develop a good rapport with the patient. You have to explain this is painful. So you have to bear up with for some time, and definitely so that the patient doesn't keep on may contract the muscles. The moment they start contracting the muscles, your findings would be totally full of errors. So therefore you have to explain that ki dila chodo, keep it loose and relax, don't worry, it's just a kind of a needle prick. Thoda sa pain hoga, little bit of pain would be there, but then it will be going over after some time. So that kind of thing has to be explained earlier. And importantly, particularly, we feel the problem where the we get the pediatric patients. So their cooperation of the child is quite important for us. And before that, the cooperation of the parents is also equally important. So we have to explain that this is just a single, we have to insert the needle, koi khoon nahi nikalne wale, first and foremost thing, which the patient's attendants are quite I mean, they are apprehensive about it. So that has to be already explained. And most of the times, thanks to the mobile, so children are mostly into the mobile and they get the procedures done. So anyways, we try to do only one or two muscles and then get away with it. Otherwise they start crying and pulling their limbs. So that is another important in the pediatric age group. Even in elderly or the adults, we find that some people are extremely sensitive to pain, and then they start creating some mess there. So that is the thing which you have to already explain. So consent is important, explanation of the procedure is highly important in this case. Then next is, of course, you have to tell what the patient has to do before the procedure. Suppose if you want to do the test the I mean the activity at the level of the biceps, you have to explain that you have to flex the muscle whenever you are being told. That is very important. And rest time, you have to keep it relaxed. So first you explain the patient what you're going to do to it. Then, of course, identification and selection of the muscle, that is also equally important. So what you have to do is how you identify. Of course, very easy. You make the patient do the movement, identify the muscle, whichever muscle you are going to do, and then check the spot, and then you have to go for the insertion. Ask the patient to relax, and then only you go for the insertion. Then, of course, you have to do it quickly for the minimal pain. And confirm the placement of the electrode by recording the contractility after a slight contraction, in case if you're a beginner or if you're not sure of where your electrode has gone into. So that is important. Then the recording technique. So before I go in, one important thing, the precautions which you have to take care while you start with the procedure. The first precaution is the temperature of the room. Okay, you have to maintain the ambient temperature of the room. It shouldn't be too cold, not too warm. So that has to be taken care of. The next thing is that you have to ask for the bleeding disorders if there are any in the patient, so that because it's an invasive procedure, so you have to take care about that. And of course, we do take care of the aseptic conditions while going for this invasive test. Okay, and so these are the specifications of how we check, we keep our system ready before the procedure. So sweeps speed is around 5 to 10 milliseconds per division. Amplification for the recording of the spontaneous activity is around 50 microvolts per division. For MUP's recording, it is 200 millivolts per division, and filter settings are at 20 to 10,000 hertz. And Duration of the MUPs has to be measured at a gain of 100 millivolts per division with sweep speed of 5 milliseconds per division, low filter, 2 to 3 hertz. Okay. Then what are the activities we record? To begin with, the moment you are inserting the muscles, you started with the procedure, you have done, cleaned the area. Then after that, what you have to do is that you have to insert the needle in it. So once you insert the needle in it, the first thing is, now the patient is at totally rest, you're not asking the patient to move so that particular limb. So when the patient is at rest, you are just inserting the needle. So that particular point when the muscle is not doing any activity, that is at resting condition, that is said to be as the recording of the insertional activity. Okay, so once you are getting, your needle is getting into it, so there, that causes a breach of that membrane and it is entering inside. So once that is being done, so then you get a recording. That's the first positive deflection. So I'll just show that. The next thing what we are doing is the, after that we are taking the spontaneous activity. Again, now your needle is inside the muscle, you're not, the patient is not moving, doing any active movement. Still then whatever recording you are getting, then it comes to us to be as the spontaneous recording without any active movement done by the patient himself or herself. Okay. Finally, you have the next phase, that is of the voluntary activity, where now you ask the patient to do the intended movement of that particular group of the muscle. Okay, so say for example, I gave you the example of a biceps. So you have to ask the patient to flex the arm. Okay, and then whatever recording is coming onto your screen, that gets into the recruitment, that is voluntary activity, which itself comprises of two parts, that is the recruitment and the interference, where the patient does it also against, forcefully against the resistance. Now, when I'm talking about the insertional activity, as I told you, the moment the needle has entered into the muscle membrane and has breached it, so you get a brief activity of the electrical activity due to this membrane damage. And what happens is that this is increased in the case of a denervated muscles or a myotonia, and decreased in the case of myopathies, where we are taking increased responses, where if it is crossing about some 300 milliseconds, that if that duration, it's, you're getting insertional activity till more than 300 milliseconds, we say it as an increased response. Okay, so you can see, like this is from a screenshot of one of my own recordings. So you can see the initial one where it has entered. So first positive deflection, it has gone in, and then it's there. Okay, the next followed by the other spontaneous activity, which we'll be just talking about in the next slides. So the next part, as I told you, after the insertion of the needle is being done, and again the patient is not doing any intentional motion. So what is happening? We are getting the spontaneous activity. So ideally, in any healthy muscle group, there would be no spontaneous activity as such. You'll get a flat line like that. Else, sometimes if you're near to the motor end plate, so you might get this kind of the end plate potential or spikes, which are also considered to be as a normal activity. So uh, th- uh, uh, normal, but as I told you, like in the any defective, or if there is any problem, you'll get the first positive potential if it is a problematic one. But suppose these end spike potentials are the ones which show a negative spike, that is above the baseline. I'll be just showing you the screenshot. And other spontaneous activities which are originating from the muscle fiber itself may be the fibrillations, or the positive sharp waves, or myotonic discharges, and the complex repetitive discharges, or the CRDs. Then coming to, and the other ones, the spontaneous activity which are originating from the motor neurons are the fasciculations, the doublets, triplets, or the or multiplets, myokymia, neuromyotonia. Now, as I was just telling you about the first, which is a normal activity, if your needle has is inserted at very much near to the motor end plate, that you then you get so you see there's a negative response. I mean, the first is the negative; it's going above the baseline. Okay, so that is considered to be as a normal activity. Either in the normal healthy muscle, as I told you, they will neither get any activity, maybe your baseline would be flat, or if you get this kind of activity, you might understand that your needle has entered somewhere near the motor end plate, and hence you are getting this kind of a negative deflection. So that has to be ignored while reporting. Then The other one, whereas you can see the rest, all if you can see these are the positive deflections, all down from the membrane potential. So coming one by one, so you can see the first one is the positive sharp waves, where you have only single positive deflection like this, or you may have a fibrillation which has initial positive deflection followed by a negative and this kind of thing, and this comes at very regular intervals, because in while we do EMG we also get a we record the sound for the EMG, and it is said that it is like rain falling on the classically described as rain falling on the terrace or something like that. So like when you're getting this, you'll get a sound like tuck 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 like that while you're recording this fibrillation. And the other one is the fasciculation, again quite resembling the fibrillation, but these are not that regular as you see for the fibrillation. You get sometimes like tuck after a long time, then tuck, like that kind of thing you will get. And again, the next is the neuromyotonic discharge. If you talk about, sorry, so there you'll have a burst of response and then again smaller. Okay, so you'll like that kind of response you get. So the next, again, the neuromyotonic discharges, as you can see over here. So you can see that it starts like a burst and then goes down like this. So that is how you're getting the difference. The next is the myokimic discharge, where you get a brief sum for five uh, coming together, and then again where then that's like again a waxing waning, I should say, coming going and coming in briefs like 4 5 4 5, like spikes like that. So that is the response seen. Now if you see, now I've put up a question for you. So if you see the first one, this one and this one, how do you differentiate? Yes, definitely. You have this negative deflection at the top. So you got to ignore that one. That's a normal finding. And these ones, which is coming very regularly, is the fibrillation and all. So so first thing is that your negative and the positive deflection has to be identified with. Then coming to fibrillation, although it's shown the spike earlier, but these are coming in a very regular fashion, if you can see. Regularity is being maintained, as I said, and the positive sharp waves, as you can see, with only the positive deflection onto there, no upper arm going that side. So that is the positive sharp waves. So again, a question for you all. Identify, please, the first one, this one. It is a positive sharp and coming very regularly. So it's a fibrillation. Okay. And the other one, if you see this one, see the first arm, it is negative. So again, a kind of end spike, but later on, lower down, you have doublets also and mixture of it. So that's a mixed picture coming in. Then myotonic discharges. These are the other group where you'll find a waxing waning pattern, where you can see that it is suddenly you can see this burst of discharge coming and then going, then coming and going. That can happen. And whereas complex repetitive discharges are the ones which will keep on happening. I mean, it comes again, the sound is very peculiar, like zerr for particular time and keeps on for a prolonged duration. So it is not a waxing waning pattern is absent there. So the doublets, I also told you, if it is from it can also be in the form of a doublets, triplets, or a multiplets or a quadruplets. So that can also be seen in the spontaneous activity. So these are all what I'm talking about is the spontaneous activity when the patient is not doing any motion, any active movement. Then coming to the next part, next phase is we ask the patient to do a particular active movement. So you see, so that's what we are recording as the motor unit action potentials, and these are the extracellular recording of the motor units. So we all are aware of what is a motor unit. So what we see in this is the morphology, and that comprises of the duration, the number of phases, sorry, the amplitude, and of course the characteristic of its firing. So going one by one, so if you can see this is a motor unit potential being shown, and you can see the amplitude. So again, as I told you, it was the first positive deflection, then goes up and down. So, and sorry, so and it has a particular duration and a particular amplitude. So comprising, if you go for the most of the values, we consider duration of about so 5 to 15 milliseconds as a normal one, and an amplitude of 200 to 2000 microvolts, again as within the normal range. So anything falling less or more, we say as a low amplitude or high amplitude, or the duration accordingly, short duration or a long duration. So then the next, the same thing. However, you can see there is a turn, but however, it has not crossed the, it is not coming to the baseline. So these are the phases as how we decide the number of phases in the, if you have too many number of these kind of activity like this, like turns over here, we say that it is not a uh, uh, single, but it is a polyphasia. So number of polyphasic. So what is a polyphasic, or how much polyphasia is allowed or considered to be as normal? So it is said that no, most of the muscles have got, should have 15% or less than 15% of the polyphasic potentials, which are considered to be as normal. But if it is an in deltoid, it is a little bit higher. It is more around some 25 to 30%, which is considered to be as a higher. That's okay for deltoid, but for the other muscles within the 25%. If it is going beyond that, we should consider that this is more telling us about, that means some injury has occurred, maybe there's a process of reinnervation or so. And this is a satellite potential which is being shown. So satellite potential is, suppose if there is certain injury has happened, and then there is reinnervation going on. So now there would be a sprouting going on, and then the reinnervation is taking place. So that is taking some time, and you're getting the potential. So by the time this reinnervation is will go on, or in a long phase, or this satellite potential will keep on moving close towards this and will merge with it with the time. So that is what is the satellite potential about. So you can see the polyphasia, you can see number of phases over here. So this is not a single one. So you have number of turns. So polyphasia over here. So we do, the software gives you, or when we are selecting the MUPs, we can select like 20 uh, spikes we select. And out of that, then the software easily tells what is the percentage of the polyphasic potentials and the MUPs. So then according to that, we decide whether it is more than 25% or less than 25%, and we say whether it is more or less. Then about the firing pattern. Now, when we are talking about the firing pattern, it is again being divided into three parts, that is the activation, recruitment, and the interference. So let's talk about it. What is this? So generally our recruitment, when we understand by the term recruitment, every one of us are well aware of it. So recruitment is actually the, if you see, simple, it is the firing frequency and the number of motor units which are firing. So both put together, it's a product of both. So say for example, if it is motor unit A is firing, and then the motor unit B is also recruited, and then we have the, now the recruitment is, that is the frequency as well as the number of motor units which have been recruited. So that is what is giving our firing pattern. Of these we take, so suppose if you're having a recruitment, suppose all the and we have been all studying from our MBBS levels, isn't it, that would best example of recruitment is like keep on pulling more and more weights, your recruitment would increase, isn't it? So the same thing, so recruitment, so we ask the patient to do the active movement. Okay, so then once you start doing the active movement like this, and then you, after recording the initial phase, you apply a little bit of the resistance and ask them to do it again. So now you have more and more of the recruitment, and that is what you see in the pattern of the recruitment pattern. Okay, so this is how it goes. So I have got three pictures over here. One is a discrete pattern, the other one is a reduced, and another is a full recruitment. So because I told you recruitment is the product of the frequency as well as the number of motor units which have been recruited. So if you see carefully, discrete is, you can see separate all, isn't it? You'll have all separate kind of spikes coming it, quite distinctive. So that is more of pointing towards some central involvement. And suppose if you're having this, although you may say that the now the amplitude is more as compared to this or this one, why you're saying there's a reduced and this is a full recruitment, it is just because this F into N, that is maintained, but you see in this one, in this it is maintained, so hence we are saying it as a full recruitment, whereas in this it is gone, you find lesser number of the spikes, so recruitment is affected. Okay, and then particularly in the neuropathies, you have large amplitude and more of a discrete or lesser recruitment as compared to the either normal ones, or in the normal cases, we will find the spikes lesser. Okay, so that is how you're differentiating between it. And I got a small video from my lab as how we are doing the procedure. Of course, I'll show on in the hands-on training session as how we are doing the procedure. Uh, so this is being done. So we're inserting it. You see that sound, please. I think so that's inverted somewhere. Okay. So the we're taking just the spontaneous activity. Okay. And sometimes you're getting the and spike potentials as well. Again, quite normal. So now I think so they've gone for the MUPs, I guess. And now the interference activity. You can see it was quite less. The recruitment was very less in this case. Very less. Although later on with increased resistance, the patient has also tried to perform the level best. So some later on we can get some of this. So this is how we are recording it and how we are getting the things done in our lab and how we're doing it. So like what I get the patients are from pediatrics, from PMR, from medicine, geriatric medicine, and of course from orthopedics, burns and plastics. So as of now, like we have done around some 525 cases from the patients alone, and around 150 or some number for the thesis cases for the postgraduate students, one from MCH orthopedics and the other one was from MS surgery, was recently completed it. So that is how what is our right now into diagnostic of our labs is. Of course NCV is done by some other faculty. So this is how we are going ahead with this kind of a thing, and these are my references, and I thank you all for a very patient hearing.
Thank you, ma'am, for sharing your expertise on fundamental of EMG. It was such a wonderful session. Now I request Dr. Hemlata, DMC Ludhiana, to felicitate Dr. Jayantipan as a token of appreciation. Our next notable speaker is Dr. Rahul Mahajan, consultant neurology, Max Super Speciality Hospital, Mohali, and an experienced neurologist with expertise in stroke management, headache and epilepsy treatment, movement disorders and dementia care, electrophysiology, presented research at national conferences, and published studies on migraine, Parkinson disease, and neuroinfection in reputed journals. He will take us through the sessions on clinical applications and reporting of NCS, which will focus on structured approach to NCS, reporting including key parameters and clinical correlation. I would request notable speaker Dr. Rahul Mahajan to please join us on the stage.
Good afternoon, everyone. Thank you, Sujit ma'am, for this opportunity to discuss clinical application of nerve conduction studies after so detailed basics of nerve conduction, and it will be rather very easy for me now to discuss this clinical application. So the first thing is when to order a nerve conduction test. So most of the requests that you'll be getting only written is NCS EMG. So the NCV, because most of the physicians, those who are writing it, don't know what exactly is NCV or EMG, because most of the times only NCV is required, EMG is not required at all. But it is always written in collective, NCS and EMG, and which limb is to be done, not written. That we have to take history and then decide further. Ha, take history also and all those things. So whenever there is a clinical suspicion of peripheral neuropathy, radiculopathy, plexopathy, or there is an unexplained muscle weakness or sensory impairment. In neurology, one thing in diagnosis is very important: localization. So we have all know about UMN lesion and LMN lesion. We come to nerve conduction and EMG only once we have ruled out UMN type of lesion, because nerve conduction will help us to localize in LMN lesion, be it nerve, be it root, be it plexus, or be it a muscle. So these are all element type of lesions which needs to be differentiated for better management. So the first thing is when to order a nerve conduction test and what to order. So if a patient is coming to you, suppose with tingling and numbness of right upper limb, usually at night, then nerve conduction test will tell you only what you know. So it is just the extension of clinical physical examination only. It will not tell you what you are not suspecting. If you don't know what to get out of the NCS, it is not going to help you much. So if a person is coming to you with tingling or numbness of right hand, usually at night, you're suspecting carpal tunnel syndrome. So you'll order a nerve conduction test of either right upper limb only, or you, for comparison, you can write both upper limbs. So that's how you order a nerve conduction test. In some cases, suppose if a patient is coming to you wasting and weakness of all four limbs for last 2 years, 3 years, and there is a history of fasciculations, there is a twitching of muscles, then you, if you are suspecting clinically motor neuron disease, then you have to write nerve conduction plus EMG as per MND protocol. So it is the first clinical examination that will guide you to dictate a nerve conduction or EMG test and which study is to be done. So these were the indications. Once you have ruled out a UMN kind of a lesion and you want to differentiate between the various LMN lesions, you need to order a nerve conduction test with or without EMG as per your discretion. So it is, we always heard from our professors that it is just an extension of physical examination. The person who is doing the physical examination should do the nerve conduction, but it can't be followed. So it is it is just that we order and then somebody else is doing it, but we need to tell them what exactly is to be done. So what it aims to establish, basically differentiation of nerve, roots, plexus, and muscle diseases. And then there are certain patterns that you need to see. If the finding in your nerve conduction studies is focal or is it diffuse, then you can establish or work up for the etiology for that particular disease. Is it predominantly motor, sensory, or it is a mixed sensory motor, or for axonal or demyelinating pattern? Every neuropathy will fit in either axonal or demyelinating or sometimes mixed pattern. And then whether NCS pattern is arising from the radiculopathy or plexopathy. So these are the 5 aims that we need to establish once we order a nerve conduction studies. So as discussed in the first lecture, first discussion, there are certain parameters that we record in our nerve conduction studies. There is a latency, both in sensory and motor nerve conduction studies. There is latency, there is an amplitude, there is a conduction velocity, and there is a F wave latency. H reflex, as ma'am has told, it is not being done routinely, and it is an, maybe in very special cases we can do it, but in routine cases we are not doing H reflex. So these are the basic 4 parameters from where we elicit our clinical diagnosis and establish what kind of neuropathy or whatever disease process is going on. So patterns, first and foremost thing that you need to establish what kind of pattern you are seeing in nerve conduction studies. Why we say we have to differentiate? Because demyelinating, if you see this myelin sheath, this is responsible for the latencies and the conduction velocity recorded in nerve conduction studies. And the axon part is important for the amplitude of the muscle or sensory action potentials. So we need to see what component of a neuron is being affected. Either it is predominantly a demyelinating process, predominantly axonal process. Sometimes there are secondary changes also that we can identify on a nerve conduction studies. So demyelinating pattern, we'll just discuss the pattern, then we'll have a case study to discuss these things. So demyelinating pattern, it means there is some abnormality in the myelin sheath of the nerves. So what we'll have is reduced conduction velocity, there will be prolonged uh, distal latencies, there will be prolonged F wave latencies, there will be conduction blocks, and there will be temporal dispersion of CMAPs. Reduced conduction velocity, we know. How it elicited the conduction velocity, we have already discussed. Latency, it is start from the stimulation to the elicitation of CMAP, that is the latency. And then F latency has been discussed in detail by the ma'am. So what is conduction block? Conduction block is because in motor studies, motor nerve conduction studies, we do two stimulations. One is distal, the other one is proximal. Whenever there is a demyelinating pathology going on, there is a drop in amplitude from the distal to proximal. So if you stimulate it from the distal side, the amplitude might be 10. But if you stimulate it from the proximal side, the amplitude might drop to 3 or 4. So if there is a drop in amplitude of the CMAPs from distal to proximal by more than 50%, it is known as conduction block, and it is a specific feature of demyelination, not a axonal process. And then there is a temporal dispersion of CMAPs, means the duration of the CMAP has increased. Examples, the lately we are aware of the GBS outbreak in Maharashtra. It is the classical example of a generalized diffuse demyelinating, predominantly motor neuropathy. And then there is a chronic inflammatory demyelinating polyneuropathy. And then there is a third entity called hereditary Charcot-Marie-Tooth neuropathy. The second pattern that we see in nerve conduction studies is reduced axonal pattern, in which there is the reduction in the amplitude of the axon or sensory nerve action potential, but there will be normal latency, normal conduction velocity, and there will be no conduction blocks. For example, the commonly we see the diabetic neuropathy, any toxin-induced neuropathies, alcohol, chemotherapy-induced, nutritional deficiencies. In this, if you remember from your physiology classes, there is a dying back axonal degeneration, and there is a Valerian degeneration. So in most of the metabolic neuropathies, there is a dying back. The distal one is affected first. So axonal pattern is usually seen in those metabolic neuropathies. And then I've just added this EMG patterns, ma'am has already explained. It just to differentiate certain clinical scenarios. When we are doing nerve conduction studies, we might have to do an EMG immediately to localize a lesion. So neurogenic pattern in EMG, there will be fasciculations, there will be large amplitude and prolonged motor unit action potentials, reduced interference and incomplete recruitment. And the other one is myogenic pattern is short duration, low amplitude motor unit action potentials, early and complete recruitment. So with this knowledge, we can classify the nerve conduction findings into a focal involvement or a diffuse involvement. Whenever we have a focal involvement, there can be a mononeuropathy, only single nerve is affected, that we can localize where the problem is lying, especially in carpal tunnel syndrome, where we can localize. Then there will be another mononeuropathy, non-localizing, in which there will be just abnormalities in nerve conduction, but will not be able to identify where the lesion is throughout the course of nerve. Mononeuritis multiplex is one condition where it happens. And then there are focal involvements in plexopathy and radiculopathy. And once we see a diffuse findings in our whole nerve conduction studies, we can we can classify into whether it is an axonal polyneuropathy, demyelinating polyneuropathy, or a mixed polyneuropathy. So with this 3-4 patterns in the background, we have a case. It's a 31-year-old male presented with complaints of tingling sensation in all 4 limbs for last 5 days. 3 days back, he started noticing weakness in the lower limbs, which progressed to upper limbs in next 2 days. On examination, there was a power grade 3 in both lower limbs, power grade 4 minus in both upper limbs, and there was generalized areflexia, but there was no objective sensory loss. So everybody knows what we are talking about here is GBS. So patient comes to us, we have ruled out a UMN kind of a lesion while examination only. The next step to initiate treatment, because today is evidence-based medicine. Just on clinical examination, we cannot initiate treatment, especially the ones which are very expensive. Intravenous immunoglobulins, we have to start in this patient, but we have to give some evidence to the patient, we need to start this. So here is the nerve conduction studies. We ordered a full nerve conduction studies of all 4 limbs. And by protocol, in upper limbs, we do a median, we do ulnar nerve, in motor nerve conduction studies, and in lower limbs, we do peroneal and tibial. So in all 4 limbs, there are 8 recordings here total. So what we see is, if you see right peroneal, here the distal latency is 5.16. Normal values, every time we have to check the book. We cannot just remember this. So normal value is around 6.5. So latency is normal. And then comes to the amplitude part. It is 9.1, 6.6. So the normal amplitude is 2. So again, the amplitude is also normal. What I've marked is conduction velocity. That is low. That is 38. The normal conduction velocity is more than 41. So we keep it more than 40. Should be normal, but it has been reduced to 38. So that is first finding. Again, the left peroneal, similar kind of findings, 38 meters per second conduction velocity. And if we come to right tibial and left tibial, 35, 36. So in the lower limbs, in all the nerves, there was reduced conduction velocity. In upper limbs, left median, in upper limbs, we keep it around 47, the conduction velocity. So it was, in upper limbs, it was reduced to 44. So by seeing this only, whether you'll say this is a focal involvement or a diffuse involvement, it has to be diffuse only, though there are not every nerve is involved, and that's what happens with acquired demyelination. Acquired demyelination, whenever the antibodies are attacking the myelin, it spares some parts. So these are the initial findings in GBS cases where only the conduction velocity has been reduced. In very classical cases, I'll show one more nerve conduction where the distal latency is also prolonged. So here, because the patient was early and the findings were subtle, this is sensory nerve conduction studies of the same patient. And again, by protocol, we do it in upper limbs, median, ulnar, and in lower limbs, we do it for sural nerves. So this is the protocol. In this, sensory is all normal. If you'll see, latencies are normal. If you'll see, amplitudes are normal. If you'll see, conduction velocities are also normal. So there is no sensory involvement. Till now, what we know is it is a diffuse motor demyelinating. And now the third part is F wave latencies. In every nerve conduction study, we do F wave latency. It has to be done. And here, so 31 is the range that we keep for the prolongation or normal F wave latency. So if you'll see right ulnar, 31.73, 31.92, 31.82. But if you'll see the motor nerve conduction studies, they were almost normal. But in F wave latencies, you have this thing. This is again a subtle abnormality, but good enough for us to convince the patient that we have evidence and we should proceed with the treatment. And how you report a nerve conduction? So we usually start with the motor nerve conduction studies. We start with CMAPs and we'll usually report the abnormal ones. So here we have reported CMAPs with normal distal latency, normal amplitude, low conduction velocities seen in bilateral peroneal, bilateral tibial, and left median nerve. F wave latency is prolonged in bilateral ulnar and left median nerve. And then there was sensory nerve action potentials with normal peak latency, amplitude, and all were normal. So what impression we have made out of this is Ensign's findings suggestive of, as we are told, it was only motor. We could not find any evidence for axonal, so it was demyelinating only because it was a diffuse involvement and it has to be polyneuropathy and it was involving all four limbs. So patient was treated as a case of GBS. GBS has certain variants also, and this was a classical AIDP variant, and he was treated with intravenous immunoglobulins and he responded to the treatment within 7 days and went home walking. So this is how you diagnose a case with help of nerve conduction studies. If I'll show just this nerve conduction studies, whether you will be able to tell it is a GBS or something else, there has to be clinical scenario, clinical context in the background of nerve conduction studies. Only then you can make a diagnosis of GBS, because nerve conduction studies will never give you etiology. It is you that you have to add the etiology to your diagnosis by taking nerve conduction studies into account. So nerve conduction studies will tell you only this thing. It is a motor demyelinating polyneuropathy. Nerve conduction studies does not know whether it is an acute thing or a chronic thing. That you have to take history and fit this nerve conduction into the whole diagnosis. So that's why we say it is just an extension of physical examination to get to the right disease. This can also be finding in chronic also. So this was about uh, demyelinating pattern. I also have a. So if we'll see this motor nerve conduction studies, and if in this left median distal latency is 6.20, the normal latency is 4.4. Then there is a left ulnar 3.49, 3.3 is considered normal. Then peroneal is 7.76, 6.5 is considered normal, and left tibial, where the latency is prolonged to 6.04, where 5.7 or 5.8 is considered normal. And then if we'll come to the amplitudes, in upper limbs, amplitudes are almost normal with mild reduction in conduction velocity. And then here the amplitudes are also gone down with reduction in conduction velocity too. So if we'll see the sensory nerve conduction studies, here sural is non-recordable, but in upper limbs, mild reduction in amplitudes with reduction in conduction velocities. And if we'll see the F wave latencies, ulnar 35, peroneal 75, and tibial is around 60. So ulnar and peroneal are definitely prolonged F wave latencies. So in this conduction study, what we have is we have a prolonged latencies, and there is also decreased amplitudes also. It's more than 4. It has to. We would have kept it normal then. Yeah. So it is 3.8. We have to keep it abnormal. Peroneal is 2 is normal, and like 0.5 is abnormal. Yeah. So velocities median 45, slightly reduced. In lower limbs, it is reduced. So it is a motor. Yes, ma'am. Yes. In motor nerve conduction studies, what we can elicit is it's a motor axonal demyelinating combined. It could be secondary axonal degeneration because majority of the findings are. Then we come to sensory. There is a sensory involvement too with reduction in amplitudes, slight increase in latencies also, with reduction in conduction velocity. So how will we report this is, impression what we'll give is, it is a sensory motor demyelinating with secondary axonal degeneration, polyneuropathy involving upper and lower limbs. So you have to see the components of the reporting. So it was motor, it was sensory, so it became sensory motor. It was predominantly demyelinating with secondary axonal degeneration. You add this part in the report, involving lower and upper limbs both. So yes, ma'am. So it is a mixed picture. So most of the times in clinical scenarios, we don't get the uh, pure demyelinating or pure axonal neuropathy. We have to decide what process is the primary one, and that is based on the predominant findings in the nerve conduction studies. This is CIDP, ma'am. Chronic inflammatory demyelinating polyneuropathy. Here the patient presented with 2 years of all weakness of all four limbs with numbness of bilateral lower limbs. So sensory is sometimes involved in CIDP, but GBS is predominantly motor only. There is a thing called sural sparing. So sural nerve is specifically spared in GBS patients. So what majority of the time GBS is motor only. There is only one variant which is AMSAN, acute motor sensory axonal neuropathy, where sensory is involved, but the classical variants are AIDP and AMAN, acute motor axonal neuropathy, where sensory is very less involved. So I hope I'm clear with the demyelinating part. So now there is a second case. Here's a 56-year-old male who presented to us with numbness below knee for last 2 years, difficulty in wearing slippers, means distal weakness for last 6 months, and then there is progression of symptoms, pinprick sensation at the tip of fingers, upper limbs, and there is a history of diabetes mellitus for last 15 years. On examination, there was bilateral feet dorsiflexure weakness, bilateral ankle reflex was absent, pain touch sensation impaired up to knees, and joint position sense impaired bilaterally in lower limbs. But upper limbs, there was no objective any sensory deficit because it is just an initial part. So here was the nerve conduction of that patient. So if we'll see the median nerve latency is normal because it is less than 4.4. We'll come to the velocities slightly reduced with almost normal amplitudes. Then left median, again slightly reduced velocities with normal amplitude. 6 is the cutoff for median. So slightly reduced amplitudes also. Little bit prolonged, ma'am. 4.4 is the normal and it is 4.79. And then there is right ulnar, almost normal latencies, slightly reduced conduction velocity, normal amplitudes. Left ulnar, reduced conduction velocity, slightly reduced because 6 is taken as the normal. And then peroneal and left bilateral peroneal is non-recordable. Right tibial, non-recordable is whenever we write non-recordable, it is after maximum effort we are not able to elicit this. So it has to be considered abnormal only. Yeah. G ma'am. So we have done our maximum effort and still not recordable, then we'll only label it as non-recordable. So bilateral peroneal were non-recordable, tibial slightly reduced, amplitude with reduced conduction velocities. Left tibial, 4 is the normal and borderline amplitude. So in this, what we can say is it's a motor nerve conduction study. So motor is definitely there, demyelination is there, axonal is there. Lower limbs are more involved as compared to the upper limbs. So what this suggests is distal, dying back degeneration, metabolic kind of a neuropathy. And then this is sensory, right median, almost normal latency, reduced velocity, reduced amplitudes. Left median, normal latency, reduced amplitudes, reduced conduction velocity. Right ulnar, reduced amplitudes, borderline latency, reduced conduction velocity, and rest, bilateral sural and left ulnar were non-recordable despite our best efforts. So sensory is also involved now. F-wave latencies doesn't make sense in this kind of nerve conduction studies. As ma'am said, F-wave latencies are most important when the CMAPs are normal. Then you will be able to localize the lesion to the roots of the uh, spinal roots. If the nerve conduction CMAPs are abnormal, then this does not hold any value or significance because it is not being conducted from the distal part only. So how will you check the proximal part? So once the distal is fine and you have only abnormalities of F wave latency, then you can say with confidence that it might be a radiculopathy. But in this case, it does not make any sense with that motor nerve conduction findings and sensory nerve conduction findings. So in this case, the reports were uh, CMAPs with normal distal latency, normal amplitude, low conduction velocity, seen in bilateral median, right ulnar, and left. So normal we have reported earlier. You can skip that part. You can just report the abnormal part, whatever is abnormal. Sorry, I forgot one thing. You have to tell what all nerves you have tested at the start of nerve conduction reporting. Only then. That demography. हाँ नहीं, that is there, ma'am. Before this, you'd have to tell what all nerves you sampled. So what bilateral median you have done, bilateral ulnar, that is at the topmost. Yes, and then you start with motor nerve conduction studies. Then there is sensory nerve conduction studies. F-wave latencies are usually clubbed with motor nerve conduction studies only. So in this case, CMAPs with normal distal latency, decreased amplitude, low conduction velocity seen in left ulnar and right tibial nerve, while it was unrecordable in bilateral peroneal nerves. You just write out the whole findings. It will help you make out the impression out of it. Yes. Non-recordable you have to. Yes. Yes, ma'am. Yes. So then there was snaps with normal peak latency, reduced amplitude, low conduction velocity seen in bilateral median and right ulnar nerves, and snaps were unrecordable in left ulnar and bilateral sural nerves. So it was NCS finding suggestive of axonal demyelinating. Why I have written axonal first and demyelinating second? Non-recordable is the extreme form of axonal degeneration. So if axonal degeneration is there and non-recordable nerves you have, it is primarily a axonal process which has further led to the secondary demyelination. So it is a classical diabetic distal sensory motor neuropathy, which can be primarily axonal but with secondary demyelination also. So then this is a third case. A 45-year-old female, known case of hypothyroidism, known case of rheumatoid arthritis. And she presented to us with tingling sensation of right thumb and index finger, usually at night, for last 6 months. And on examination, there was mild wasting of right thenar eminence and sensory impairment on the palmar aspect of thumb and index finger. Now, what we are talking about is carpal tunnel syndrome. So we know beforehand, before ordering a nerve conduction. So we'll order a nerve conduction studies, right upper limb only. So here, if you'll see the whole motor nerve conduction studies, the only abnormality you will see here is left median 5.94, which was normal was 4.4. Everything else is in normal range. Even the conduction velocity is also in the normal range. And then there is a sensory studies, right median, left median, right ulnar. The only abnormality seen is peak latency, that is 4.64, while the amplitude, if you compare it to the other side, it is reduced but still in the normal range. So we'll not report it as abnormal because it is still in the normal range. And if you'll see the velocity, it is 32 only. So what we make out of it, motor is involved, single nerve, so it has to be a mononeuropathy. So if you remember the previous flow chart, mononeuropathy, localizing or non-localizing. So whether we can localize here or not, That is the question. Here we have a finding where only the distal latency is prolonged, but velocity from the proximal site is normal. So what you will think? You will think distal, yes. So where you are stimulating the distal part, from that part there is some problem. So maybe it is a localizing. Again, same, sensory is also involved. So sensory motor component of median nerve has been involved, demyelinating kind of a thing. We can localize it to a wrist part because the velocity in the proximal part is normal. So how will we report this? CMAPs with prolonged distal latency, normal amplitude, normal conduction velocity seen in left median nerve. F wave latencies were normal. Snaps with normal peak latency, normal amplitude, and normal conduction velocity seen in right median and bilateral ulnar nerves. An impression was NCS findings suggestive of left median neuropathy with focal demyelination, because we could not generalize whether the demyelination has been there in the proximal segments or two, due to likely compression at wrist, and that is this clinical scenario is carpal tunnel syndrome only. So that's how you report a carpal tunnel syndrome report. Are you bored or should we move ahead? So this is the last one. First, in nerve conduction studies, we have to find a pattern, whether it is axonal or demyelinating. The second thing we have to notice is what kind of nerves are involved. Is it pointing towards a single nerve? Is it pointing toward a nerve coming from a single root? Or is it pointing towards a nerves coming from the plexus? So we can sometimes localize it to the plexus root also with the help of EMG2. So the next case is 33-year-old male presented with complaints of weakness and numbness of right lower limb. And there is a history of intramuscular injection right gluteal region by a local quack. On examination, there was marked wasting of muscles of right lower limb except thigh muscles, and there was a complete sensory loss below right knee. So you must have got an idea what I'm talking about. Intramuscular injection directly into the. So what we'll see in the nerve conduction studies is we have done bilateral lower limbs for comparison. So what we saw, right peroneal non-recordable, right tibial, though latency is normal, amplitudes are markedly reduced with reduced conduction velocity too. Left peroneal and left tibial are almost normal. So there is no abnormality on that side. So here both the peroneal or tibial are involved. So is it a mononeuropathy? It is not a mononeuropathy, but is it a diffuse involvement? Because other side is normal. So it is not a mononeuropathy, it is not a polyneuropathy. So it is some pattern that we need to fit in some kind of lesion. Sensory, right sural and right superficial peroneal nerve were non-recordable. Left and superficial and sural were normal. So what we have till now is there is a motor involvement of tibial, peroneal, and then there is a superficial peroneal and sural involvement. So the lesion is beyond a mononeuropathy level. It ऐसा तो नहीं हो सकता कि किसी ने दोनों नर्व काट दी हो या कुछ ऐसा कोई ट्रॉमा, ऐसा कोई ट्रॉमा भी नहीं हो सकता कि जिसमें दोनों नर्व्स चली जाएं, चारों नर्व्स चली जाएं. So it is because of something in the back, that is whole of the nerves of lower limbs are degenerating. Valerian degeneration, what we were talking about. It starts degenerating if there is a proximal lesion. And then F wave latencies are there. Again, it does not make much sense at this point of time. We already, if it is non-recordable and amplitude is not there. So what we have made of these findings is CMAPs were unrecordable in right peroneal nerve with low amplitude in right tibial nerve. F latency is prolonged in right tibial and non-recordable in right peroneal nerve. Snaps were non-recordable in right sural and right superficial peroneal nerve. So whatever is there in the right lower limb only. So it is not a diffuse but it is not limited to a single nerve too. ठीक? Then what we said is based on NCS findings of sensory motor, predominantly axonal involvement in right tibial, peroneal, sural, and superficial peroneal nerves. These nerves come from sciatic nerve, then there is a lumbosacral plexus, and then there are roots. So what we have accomplished is it is at the either at the level of sciatic nerve, or at the level of lumbosacral plexus, or at the level of roots. नर्व कंडक्शन स्टडी से इससे ज्यादा हम लोग डिकोड नहीं कर सकते. So what we did was EMG. So there is a EMG was done in gluteal muscles. Sciatic nerve does not supply gluteal muscles. If it would have been plexus involvement, there must have been changes of denervation or reinnervation in the gluteal region. Because that was normal, we thought it is a below that part and it is the sciatic nerve that has been involved. So that's how you localize a pattern into this thing. So again, so plexopathy, first you need to know what kind of nerves are coming out of that plexus, what kind of muscles are being supplied, and then you have to find a pattern in all those things to determine whether it is a plexopathy or a radiculopathy. Very simple method. प्लेक्सोपैथी और रेडिकुलोपैथी में ज्यादा फर्क नहीं होता एक्सेप्ट द ईएमजी चेंजेस इन पैरास्पाइनलिस मसल्स. If you see EMG changes of denervation or reinnervation in paraspinalis muscles, you will localize it to the roots because plexus will not supply paraspinalis muscles. It is only the dorsal rami of spinal root that will supply the paraspinalis muscle. So only if the root is involved, you will see the changes in paraspinalis muscle. Otherwise, you will see the changes in rest all the muscles in both radiculopathy and plexopathy. So this was from my side. Thank you so much.
Singa
You always need to see Shapiro whenever it's required. We can't remember all these values. So whenever we report, we have a chart pasted on the wall of our neuro lab. So only then we can report this. And also that muscles, plexus, and all those in those special studies.
come to an end of this academic conference, I take this opportunity to invite Dr. Rachna, Professor and Head GMC Patiala, to facilitate Dr. Rahul Mahajan as a token of appreciation. Dear delegates, we are pleased to inform you that the certificates of participation for CME are ready for collection. You are kindly requested to collect your certificates from the registration desk at your convenience. We sincerely thank you for your participation and contribution to the success of this CME program. We will now break for lunch, which is served in the medical education unit, fourth floor. Post lunch, we will gather again at 2:30 p.m. in room number 30, Physiology Department, first floor, for the workshop. Thank you.